I think being paid on an outcomes basis is always possible as long as you can measure what you're doing. So it becomes less relevant in little populations or something. Then it becomes, what is the right care model that you're applying to that population? And so again, going toward things that sound good, you'll have some people talk about, in essence, what I would consider a very heavy clinical model, maybe Landmark-like or other clinical models applied to the broad Medicaid population, for example. Now, like in my opinion, that sounds great, right? There's no question that Medicaid patients don't receive the same level of care as commercial patients, largely because Medicaid pays less. There's improvement to be made, and there's inequality in our healthcare system. However, if you are going and taking outcomes risk and doing a heavy model for all Medicaid patients, like, to be clear, Medicaid patients are not all sick. They are poor. And so you can't just give massive amounts of heavy care to every single Medicaid patient, because while on average, a Medicaid patient is not as healthy as a commercial patient, usually, that's a very different thing than treating older people that tend to have more health problems because they're older. So all this to say, I think it's really important, and you can take risk in Medicaid, by the way, but the model needs to match the needs of the population and needs to be set up the right way, or else it just will sound good and fundamentally not work. And so I think you can take outcomes-based payment, whether it's full risk or not, in any population, as long as it's tailored the right way, and as long as honestly the N or the number of patients is high enough to where it's a measurable thing.
Yeah, no, that makes a lot of sense. And obviously having, enough concentration in the areas you're operating in as well, makes a tremendous amount of sense. I mean, I'm kind of curious, obviously you were on the policy side for a bit, and it feels like most of these models have happened in Medicare Advantage to start. I think obviously there's lower reimbursement rates in Medicaid, but wondering, as you think about like the policy side, anything that can be done to kind of continue accelerating these models, beyond Medicare Advantage.
So I think there's a bunch of reasons why Medicare Advantage has started, or Medicare generally. Like, so when my intent at CMMI relative to models like direct contracting, which became REACH ACO, like other models, was to enable physicians to take risk or take outcomes-based payment, right, in ways like they would do in different markets. From a Medicare Advantage perspective, or Medicare perspective, a couple elements. One is it's an older population, and it's easier to take risk on an older population. The hardest thing to take risk on, in a way, is a healthy population, because when you think about bell curves, right? It's why, by the way, this is why exchange plans lost so much money at the beginning. They had no history. And if you think about healthy patients and a bell curve, there are a lot of people that have no healthcare cost. And then at the very far end, there's a lot of people with multi-million-dollar healthcare cost. That's a really difficult thing to ensure, especially without history. Medicare Advantage populations are easier to insure. Because let's say average age, I'm making this up, I don't think let's say it's 72, 75. There aren't that many people at that age that don't have any medical issue at all because they're older. Right. And at the very far end of the scale, think about people that have multi-million-dollar significant healthcare claims. Those are car accident victims, NICU babies. Those are generally not 90-year-old people that are complex and chronic. If they get in a car accident like that, they're not getting a transplant, et cetera, right? So it looks like a bell curve. It's easy to insure. That is one reason. The second reason is there are lives in insurance companies to take risk on. We can get into other areas. And then some of that, and then from a care model perspective, you can make a difference. You had a risk adjustment mechanism. There's discussion back and forth on documentation and approach. So there's a number of elements, I think, that made it successful. I think as you look at other populations, I'll tell you some of the difficulties, even from a policy perspective. Medicare tends to be easier because it's federal to make major differences. When you're in the administration and you're running things, and think about actually the person that runs state now for CMS is fantastic. I actually tried to recruit him a lot when I was at CMMI. I think he's really great, came from Massachusetts, but he does not control every state Medicaid plan, obviously. And so he has more limitations in what he can tier down. Move over to commercial, and again, your government ability to impact things at scale is harder, let alone the commercial healthcare plans mostly don't even insure the population. They operate on an ASO basis, so they're insured by individual employer. So I would say the difficulty you have in commercial and Medicaid is, to some extent, less impact because they're not as sick. Fragmentation in base in how you drive it. And so those things make it more difficult, and incentives make it more difficult. That said, I think it's really important because I think that if you think about generations of risk model, you can't just rely on one population. And I do think that risks and outcomes-based payment will evolve, and that physician groups will evolve to saying, okay, we're doing some of the easier things. Now let's think about how to take the next steps. So how do we think about multi-specialty groups where folks are employed? How do we think about, like a cataract surgery? Why are we not doing that in office or ASC versus a hospital? Like there examples like that where you start saying that's really silly from the perspective of cost, from a patient care perspective, from a convenience perspective. And I think those will be next generation things. And the nice thing about Medicare is you could build out around that. And I think that's kind of the next approach.